Vedete dallo schermo?
Sì. Sì.
Sì.
Another way to understand the generation of alpha rhythms is to investigate the relationship between brain diseases and changes of e.g. alpha rhythms in relation to healthy subjects. So you see here that the relationship we are interested in are from the disease changes in the brain of patients, the changes in the vigilance, in the regulation of brain arousal, and changes in the e.g. alpha activity as revealed by spectral analysis. You see that the changes of e.g. waves over time can be represented by power density of this e.g. activity in the typical spectral analysis. And so these are the results of a study of my group on special patients with some brain diseases over the tentorium in the brain. You see in the left side of the picture the tentorium, the red line, separating ideally the brain hemispheres from the brainstem and cerebellum. So patients with traumatic infectious or other kind of physiopathological processes, the patients having lesions over the tentorium in the brain can present a special clinical manifestation called persistent vegetative state. These patients show a normal wake-sleep cycle, so they can sleep during the night and they are awake during the daytime. However, they do not show the typical signs of a person with the normal consciousness state. So these patients are not reactive to the environmental stimuli, in the sense that, for example, the relatives or friends or the medical staff, people can ask for questions to these patients, but the patients cannot react in any way, cannot answer, cannot show any sign showing that they are aware about the questions, they are aware about what is happening in the environment surrounding them. So they have practically no conscious activity, no ability to communicate the mental representations. So the idea is that these patients can represent a pathological brain model of severe consciousness disorders. And so you see the results of an experiment in which we recorded the EEG activity in the resting state, the eyes closed condition, in a group of people with normal cognitive activity, healthy people, as a control group. In the second line, you see patients with persistent vegetative state that at the time of EEG recording were in the clinical condition of persistent vegetative state. But after 3 months from the EEG recording, recovered a mild level of consciousness and were able to react in some way to the input from medical staff and the relatives. And so we call them persistent vegetative state, recovering after 3 months, some consciousness level. In the bottom line, you see the results in patients with persistent vegetative state at the time of EEG recording that did not recover any consciousness level after 3 months. And so we call them non-recovering. You see that any column is related to a frequency band of EEG, delta from 1 to 4 Hz, theta from 4 to 7 Hz, alpha 1 or low frequency alpha from 8 to 10 Hz, high frequency alpha from 10 to 12 Hz, and then beta 1 from 13 to 20 Hz, and beta 2 from 21 to 35 Hz. You see in the maps the cortical model of Iloreta software, which is a freeware allowing you to use scalp recorded EEG activity and a model of the head as a volume current conductor to estimate the cortical source activity explaining the scalp recorded EEG. And you see that red in the maps means high source activity. In the map is a top view of the cerebral cortex model of Iloreta, and the nose is up in the picture. So you see that in the control healthy participants, there is a clear dominance of source activity, cortical source activity in the posterior cortical regions in low frequency alpha or alpha 1. And also a significant source activity in the cortical model of high frequency alpha or alpha 2. You see that there is no particular source activity in beta 1 and beta 2, and there is a mild cortical source activity in delta and theta in comparison with the source activity in alpha frequency bands. And so you see that in the two groups of patients with persistent vegetative state and consciousness disorders, you have a dramatic drop of cortical source activity in alpha rings. You see that the red spots are significantly reduced. So one can conclude that there is an association between the consciousness disorders in patients with persistent vegetative state and posterior alpha source activity in the resting state as closed. And so this is a demonstration that patients with brain diseases can help you to understand the physiological and mental correlates of EG alpha activity. These are results of another experiment we performed on patients with the so-called long COVID syndrome. These patients were hospitalized for respiratory distress due to COVID-19 after 1 year from the hospitalization. They still presented some symptoms related to the time of COVID infection. They, of course, recovered from COVID-19 infection after 1 year, but still they had some mental fatigue, some difficulties in concentrating, difficulties to pay attention and to memorize something. So they refer to the so-called brain fog, which is a clinical state with some disorder of vigilance and some subjective cognitive subjective cognitive impairment or complaints. So we measured the number of long COVID brain fog symptoms by means of an inventory called the Pole questionnaire. And so we were able to say this person had 3 symptoms of long COVID brain fog, or 6 symptoms, or 9 symptoms, and so on. We administered the neuropsychological and clinical tests to these patients with the long COVID or post-COVID syndrome, and they did not show objective clinical deficits. So they had some subjective cognitive complaints not confirmed by neuropsychological tests. And so you see the resting state EEG results using the cortical source analysis by Iloreta Freeware. You see in this graph in the vertical axis that you have the cortical source activity. In the horizontal axis of any rectangle, you have the frequency subbands, very low frequency alpha, typically around 7-8 hertz, individual low frequency alpha around 8-9 hertz, and high frequency, individual high frequency alpha, typically from 9 to 11 hertz. In this particular experiment, we refine the alpha frequency analysis and the bands, the subbands of alpha rims were established by means of individual alpha frequency peak in the power density spectra. And so you see that we have 3 groups of participants. The blue group is a healthy control without cognitive deficits and matched as age, sex, and education attainment. And you see in blue that the higher source activity was observed in the alpha frequency, high frequency alpha, in the occipital and parietal cortical regions in the cortical model of Iloreta software. In green, you have the patients with the post or long COVID-19 having more than 3 symptoms. And you see that they have similar source activity in relation to healthy control subjects. And so you see that even also in these post-COVID patients, you can see normal alpha frequency source activity. But if you consider the group of post-COVID or long COVID patients with more brain fog symptoms, so more in the red group than the green group, you see that the patients with more brain fog symptoms show a clear decline of alpha source activity in several regions, especially parietal and occipital. And so I emphasize that and repeat that green and blue groups of post-COVID patients did not have any cognitive deficits based on a neuropsychological test. So just the subjective mental self-perception of fatigue, mental fatigue, and difficulties in concentrating, and so on. And so we could confirm that patients with more mental fatigue, more difficulties in concentrating, the subjective sensation of difficulties in memorizing, these people with more brain fog symptoms suffer from vigilance dysregulation related to alpha source activity reduced in intensity in posterior cortical regions. So this is another nice demonstration that you have a strict association between the mental fatigue, vigilance dysregulations, and changes in alpha rhythms in the posterior cortical sources in the condition of resting state, eyes closed. Another chapter of our studies on brain diseases and resting state EEG activity was performed on patients with neurodegenerative diseases belonging to severe cognitive deficits and disabilities in the activities of daily living in pathological aging. You see in the picture an older person suffering from cognitive functions, dysfunctions, such as difficulty with everyday tasks, difficulty with communication and language. For example, they sometimes have difficulties to communicate using language, to use the right words to nominate objects, to build up a statement or a speech. These patients with severe cognitive deficit can become lost in familiar places or became unaware of time and show forgetfulness for recent events. They, for example, have difficulties to recognize a person based on the face. They say that there is some familiarity. They meet that person another time or sometimes, but they do not remember where and who is the person. Other symptoms are also observed in the domain of mood. For example, some depression or some apathy, and also in some behavioral domains, such as, for example, sleep with some sleep disorders or some aggressive behavior. So when the symptoms are so severe to make very difficult to live with autonomy and independence in the activities of daily living, in that case, the geriatrics or neurologists or psychiatrists can give the diagnosis of dementia in older people. The results I will present are obtained by a network of researchers and institutions in several places in Italy, in Europe, and even in Asia. You see the names of these persons from Spain, from German, from Switzerland, from Turkey, and also South Korea. So the dementia is a clinical syndrome that can be due to different neurodegenerative diseases. The concept of dementia is similar to the concept of fever in medicine. So is a symptom reflecting several different diseases. So it's very important to qualify the presence of dementia with measures in vivo of neuropathology. For example, A-beta amyloid in blue is a protein which accumulates in the brain during the pathological aging. And you see here this accumulation of A-beta amyloid protein in the medial frontal cortex and medial posterior parietal cortex. And another protein characterizing the pathophysiological process of Alzheimer's disease is tau protein. And you see in orange the localization of tauopathy in the brain of patients with Alzheimer's disease. So the neurobiology can help to give the diagnosis of Alzheimer's disease with measures in vivo of A-beta amyloid and tau by means of positron emission tomography using antibodies linking to A-beta amyloid or tau, or the measures in vivo of A-beta amyloid and tau from cerebrospinal fluid, sampling cerebrospinal fluid with the lumbar puncture. And you see here in this graph from the left to right, the progression of Alzheimer's disease from the preclinical stages in which you can find only tauopathy in the mesial temporal lobe, including a hippocampus, as some you see nuclei in the brainstem. So this is very important because you see that the neuropathology of Alzheimer's disease is present before the clinical manifestations of cognitive deficits or disabilities in the activities of daily living. So even without objective cognitive deficits, you have some neuropathology in the brainstem, which is the structure in which you can find the reticular ascending formation, the ascending subcortical neuromodulatory systems arousing the thalamus, the forebrain, and the cerebral cortex, and regulating the level of vigilance and the brain arousal. So you can expect that even before the clinical deficits in Alzheimer's disease patients, you can find changes in the EEG rhythms and alterations in the vigilance regulation. During the course of Alzheimer's disease, in some cases, 1, 2 years, 4 years, or 5 years, you have more accumulation of neuropathology in the brain. And so you see here the amyloidosis in the cerebral cortex and an expansion of tauopathy. When you have this interaction, you see the black arrows of interaction, pathological interaction between tauopathy in orange and amyloidosis in blue. You have some neurodegenerative processes reducing synaptic connections, affecting the neurotransmissions, and inducing the death of neurons. So the neurodegenerative processes include losses of synapses and neurons in the brain. And in that case, these changes in the brain volume in some places, the changes, abnormal changes in neurotransmissions and the functional connectivity between brain regions induce deficits in the cognitive functions. And these objective deficits and these deficits are called mild cognitive impairment. In the case of mild cognitive impairment, you have an objective measure of cognitive deficits. In the case of mild cognitive impairment, you have patients who are still able to be autonomous in the activities of daily living, for example, shopping or use of devices, electronic devices, the TV remote controller, or the machines to obtain tickets, to use public transportation, or and other driving car, even driving car. During the progression of Alzheimer's disease, which is progressive, and so there is some deterioration of brain structure and functions over time. So at a given point, for example, after some years, you can measure an increase in the accumulation of tauopathy and amyloidosis in the brain. So you see orange and blue expanded in the brain, interacting more and more. In this case, the structural and functional deterioration of the brain is related to worsening of cognitive functions. And so the neuropsychological tests and the clinical scales show this worsening, and the cognitive deficits became more and more deteriorated, and you lost your autonomy in the activities of daily living. In this case, the patient will receive the diagnosis of dementia due to Alzheimer's disease when there is an in vivo measure of brain abnormal amyloidosis encephalopathy. So ideally, you can expect that you have changes in alpha RINs and the regulation of vigilance, even in the preclinical stages of Alzheimer's disease, with mild neuropathology in the brain. That these changes of EEG reflecting vigilance regulation appear to be deteriorated in the mild cognitive impairment in relation to preclinical stages and normal subject, normal condition, and even more deteriorated and changed in the stage of dementia due to Alzheimer's disease. And here we have the results of an experiment in which we compared the cortical sources of a resting state, eyes closed EEG activity in two groups of patients with mild cognitive impairment. In these patients, we obtain the cerebrospinal fluid with the lumbar puncture. We dosed the amyloid beta 42 and phospho-tau and other neuropathological species. And based on a threshold, we could identify the patients with Alzheimer's disease with mild cognitive impairment, and they are the red group. The patients with mild cognitive impairment, based on a neuropsychological testing, but negative to diagnostic Alzheimer's disease biomarkers from cerebrospinal fluid, were called no mild cognitive impairment not due to Alzheimer's disease. And they are in the blue group in the graph. You can see the typical graph. In the vertical line, you have the intensity of source activity generating EEG. In the horizontal line of the rectangles, the frequency bands of EEG activity from delta to gamma. And then you have the different rectangles show the cortical regions of interest in the cortical mathematical model of Iloreta: frontal, central, parietal, occipital, temporal, and the limbic. In blue, non-Alzheimer's disease by cognitive impairment show a clear peak of alpha source activity in the occipital region, and also remarkable cortical source activity in the parietal alpha. In the group of Alzheimer's disease with mild cognitive impairment in red, you can see a significant reduction of alpha source activity in occipital cortical region and the parietal cortical region. Furthermore, you see that there is an increase of delta source activity in the temporal and frontal cortical regions. So we have an interesting results showing that even if you have two groups of mild cognitive impairment patients, in the two groups you have the same level of cognitive deficits, but different alpha source activity and delta source activity in the resting state, eyes closed, showing that compared to mild cognitive impairment not due to Alzheimer's disease, the patients with Alzheimer's disease with mild cognitive impairment in the red have more changes in alpha source activity, reflecting more changes, more dysfunctions in the vigilance regulation. This is to emphasize that we have not only the dimension of cognitive functions, but also another dimension, which is the dimension of brain arousal and vigilance regulation, which is reflected by alpha source activity in the resting state, eyes closed, and also delta source activity. A typical brain disease related to vigilance disorders, brain arousal disorders, is epilepsy. And the clinical diagnosis of epilepsy is typically based on, of course, myoclonic motor symptoms during the epileptic seizure, but also disorders of consciousness. For example, absence epilepsy that you can see in some patients who have some consciousness loss during the period of epileptic seizure. They can remain awake, they can be seated in front of the medical doctor, but they can be confused, or they can be in a sort of frozen state of the mind. So epileptiform activity in the EEG activity may reflect vigilance dysfunctions in patients with Alzheimer's disease and other neurodegenerative diseases. For this reason, we perform a study in which we evaluated the EEG activity during about 40 minutes in a condition we called resting state, eyes closed, and with the prolongation of time, allowing a person seated in an armchair comfortably to have a transition from quiet vigilance to light sleep across the stages of sleepiness, drowsiness, and sleepiness. And you see that we could observe in 8 Alzheimer's disease by cognitive impairment patients this kind of epileptiform activity according to the international guidelines to recognize this epileptiform activity in patients. I emphasize that these Alzheimer's cognitive impairment patients never received the clinical diagnosis of epilepsy. So they are, from a medical point of view, patients without epilepsy, clinical epilepsy. However, they show this kind of epileptiform activity in the EEG. And so you see in the red rectangle, the spikes associated with the reduction of background alpha rhythms. In the subject 2, a sequence of spikes and slow waves related to reduction of background alpha rhythms, and so on in the other subjects. They were about 20% of the Alzheimer's disease patients evaluated by our epileptologists. They receive the marker of epileptiform activity when at least 2 epileptologists out of 3 epileptologists recognize the epileptiform nature of these waves. After this preliminary analysis, we compared the resting state, eyes closed, EEG source activity in 3 groups of participants. The blue group was formed by healthy older people as a control group. The red group was formed by Alzheimer's disease by cognitive impairment without epileptiform activity during our long resting state EEG recordings. In the green group of patients, we included Alzheimer's disease by cognitive impairment patients showing the epileptiform activity, the 8 participants with Alzheimer's disease by cognitive impairment of the previous slide. And so if you see the healthy old people, you see source activity peak in alpha frequencies in parietal and occipital regions of interest. In red, you see the group of Alzheimer's disease MCI without epileptiform activity, and you see a clear drop of alpha source activity. However, this drop is very similar to the drop of alpha source activity observed in Alzheimer's disease by cognitive impairment, showing epileptiform activity in green. So you see that basically the reduction of alpha RIMS did not differ between Alzheimer's disease, cognitive impairment patients with and without epileptiform activity. In contrast, you see that especially in occipital and temporal cortical regions of interest, you have an abnormal increase in delta source activity in Alzheimer's disease, cognitive impairment without epileptiform activity, but the abnormal increase is ever more pronounced in patients with Alzheimer's disease, cognitive impairment, and epileptiform activity. And you see these in the occipital and temporal cortical regions of interest. So this is an interesting study showing that when you see the resting state, eyes closed condition, and record EEG activity in Alzheimer's disease with cognitive impairment, you can have more abnormalities in the EEG source activity, in this case in delta, when you have epileptiform activity, which can reflect more vigilance dysfunctions, which are typically related to this epileptiform activity. So this is another demonstration that EEG activity in the resting state, eyes closed, can change in the patients with brain diseases due to Alzheimer, and this can be related to vigilance dysfunctions. Alzheimer's disease is a very interesting disease to understand the neurophysiological mechanisms generating EEG activity in the resting state, because it's a disease in which there is a special disruption of ascending cholinergic system. The neurons using acetylcholine as a neurotransmitter to change the activity level of cortical neurons. Indeed, Alzheimer's disease is strictly related to cholinergic system, as revealed by the most popular pharmacological intervention, the treatment with acetylcholinesterase inhibitors, which are able to increase the tone of cholinergic neurotransmission. This is a therapy symptomatic because it can improve concentration, episodic memory, mental activity in the patients for about 1 or slightly more periods of the disease. So it's not something that can stop the Alzheimer's disease, can just relieve some cognitive functions for a relatively short period of 1 year or slightly more. Together is today the most diffuse therapy for all patients with a diagnosis of Alzheimer's disease. So one would expect that changes in the EEG activity during a resting state are related to cholinergic dysfunctions in Alzheimer's disease patients. And so we tested this hypothesis, exploiting a discovery of a group of experts of cholinergic system and neuroimaging. In this group, American group, was able to define the places in the brain in which the cholinergic tracts from basal forebrain to cerebral cortex are localized. And you see in this picture that you have two slices of magnetic resonance imaging, and you have in yellow, red, and green the specific pathways of ascending cholinergic systems. So in your magnetic resonance imaging data, you can use these masks of ascending cholinergic tracts to cerebral cortex to measure the lesions, the degeneration or alterations, especially in these tracts. This is what we did. In this experiment, we measure the lesions in the cholinergic tracts from magnetic resonance imaging and could estimate the degree of deterioration of ascending cholinergic system. And so we could divide a group of patients with Alzheimer's disease with mild cognitive impairment in two subgroups. The subgroup with more cholinergic tract lesions, C+, and the group with less lesions in the cholinergic systems, or mild cognitive impairment, C-, cholinergic minus, cholinergic plus lesions. And then we use a group of normal elderly persons as a reference in the analysis. And you see here the group results of this experiment. In the line of a normal old group, you see the typical dominance of source activity in the alpha frequency range in healthy subjects, nose up in the maps. In the group of Alzheimer's disease, mild cognitive impairment with less lesions in the cholinergic system, you see a clear reduction of alpha source activity. And in the group of mild cognitive impairment due to Alzheimer's disease with more lesions in the cholinergic system, you see a reduction of alpha source activity, but interestingly, more than the group of Alzheimer's disease MCI with less lesions in the cholinergic system. So it seems that the cholinergic systems can affect the generation of resting state, eyes closed alpha rims in Alzheimer's disease by cognitive impairment patients. And so this is a nice demonstration that changes in alpha rims are strictly related to Alzheimer's disease neuropathology in the experiment with cerebrospinal fluid biomarkers of amyloidosis and tauopathy, and is related to ascending cholinergic system. And so these conditions, pathological conditions, can affect the ascending subcortical neuromodulatory systems regulating brain arousal and quiet vigilance in wakefulness in Alzheimer's disease patients. Here we have another interesting experiment on the impact of cholinergic system on the generation of resting state alpha rims in Alzheimer's disease patients. In this experiment, we enrolled Alzheimer's disease patients with dementia. And we performed 2 resting state, eyes closed EEG recordings. One before to start the cholinergic therapy with acetylcholinesterase inhibitors. And the second EEG recording was performed 1 year after the beginning of the therapy. This is a complex graph which illustrates the difference of EEG source activity in the resting state as closed between the 2 EEG recordings. So you have 0, the horizontal blue line, when you have the exact source activity in the 2 EEG recordings. You have negative values of the difference when you have a decrease of EEG source activity in the second recording after 1 year, in comparison to baseline recording. You have positive value when you have an increase in the source activity after 1 year of the therapy in relation to the baseline EEG recording. In the graph, you have 2 subgroups of Alzheimer's disease patients with dementia. In blue, you have responders to the cholinergic therapy, which means that these Alzheimer's disease patients show the same level of cognitive functions from a neuropsychological test after 1 year of cholinergic therapy. So they were stable over time, probably due to the efficacy of cholinergic therapy. In red, you see the subgroup of Alzheimer's disease patients who show a decline of cognitive functions after 1 year. So the neuropsychological test scores indicated a cognitive decline. If you see the results, they show that the non-responders to the therapy had a dramatic reduction, negative values in the graph of alpha source activity in the occipital especially, and temporal cortical regions. Interestingly, the group of responders to the therapy, even with stable cognitive function, showed a decline of alpha source activity in the same regions, occipital and temporal. But the reduction was not so strong as the reduction of alpha source activity in Alzheimer's disease patients non-responding to the cholinergic therapy. So the interesting finding is that after 1 year, you have a significant decline of alpha source activity in these patients. But the reduction of alpha RIMS was much greater in the Alzheimer's disease patients with dementia, not responding to the cholinergic therapy and showing a cognitive deterioration after 1 year. So this is another demonstration that cholinergic systems are important in the generation of AG activity during the resting state as closed. And the different reactivity of cholinergic systems to the therapy are reflected in EG source activity in alpha RIDS. In this picture, you see in the right side the results of a typical experiment of a resting state functional magnetic resonance imaging. In this case, you have exactly the same condition of a resting state, eyes closed, mind wandering, no goal-directed mental activity, no voluntary movements, behavioral state of psychophysical relaxation, like the EG recordings in the resting state eyes closed. The magnetic resonance imaging scanner records the so-called bold signal, which we have defined in a previous slide. And this bold signal is the ratio between the blood oxygenated hemoglobin in relation to blood deoxygenated hemoglobin. And this ratio gives us a measure of brain activity during the resting state condition. In the specific analysis of resting state functional magnetic resonance imaging, you have a time series of bold activity over time for about 10-15 minutes. And you have this time course of bold activity for each voxel of the brain space during the analysis of magnetic resonance imaging. And the objective of the data analysis is to compute the correlation between the bold activity in one cortical region, for example, posterior cingulate cortex, the regions I are indicating with my laser point, and all other voxels in the brain space. And the typical result of this analysis is that the posterior cingulate cortex is strictly correlated with the inferior parietal cortex in the left and right side, in medial prefrontal cortex, and especially, and also anterior cingulate cortex. And so this strict correlation between cortical regions during resting state, eyes closed, is named default mode network, because this strong correlation is much higher during a resting state, eyes closed, than during cognitive tasks, showing that this network is especially active when the person is not involved in cognitive tasks and activation of attention, decision-making, and other visual object information processing. So this strict relation between a resting state condition and default mode network is especially interesting for our objectives to understand the neurophysiological and functional neuroanatomical basis of the generation of a resting state EEG activity. In this study of Bowman and colleagues, they performed a comprehensive analysis of a resting state functional magnetic resonance imaging, the analysis of correlation of both signals in different places of the brain, and the simultaneous recording of resting state alpha rhythms in the EEG activity. So it was a so-called multi-modal recording of resting state magnetic resonance imaging and EEG in healthy adults. And then they decomposed the bold signal and EEG signal to understand the cortical regions showing a significant negative correlation between EEG alpha and bold signal in red, and positive correlation between EEG alpha and bold signal. In the case of negative correlation, you have the case of high bold and cortical activity and low alpha rhythms as a sign of cortical activation. And this is the typical case. In the case of positive correlation, you have the case in which a decrease of bold activity, so less cortical activity, is related to low alpha EEG activity. And so you see that in these results, they could demonstrate that in the case of high cortical activity in the posterior cingulate cortex and medial parietal cortex, this area in the brain model, and in the inferior parietal cortex as nodes of the full mode network, and in the medial prefrontal cortex, in this case of cortical activation and high bold activity, there was a sort of sentinel function in the regulation of vigilance, emphasizing the monitoring of the environment. In this case of positive correlation between EEG and bold, with the blue hypoactivation of a frontal lobe, you have a sort of introspective activity, attention to our body, our autobiographic memories in the condition of introspection. So the default mode network can be implied in this oscillation between the introspection and the function of monitoring of external world. So this is the basis for our hypothesis that in Alzheimer's disease patients, which typically have deterioration of the default mode network from magnetic resonance imaging studies, in Alzheimer's disease patients, this dysfunction of the default mode network may be related to changes of alpha EEG activity. And this was the case in the results of our experiment. You see in this slide that we were able to identify the typical nodes of the default mode network in our magnetic resonance imaging. You see in the graph medial prefrontal cortex and anterior cingulate cortex, the posterior cingulate cortex, the inferior parietal cortex, and also the precuneus, so close to posterior cingulate cortex. And when we analyze the normalized gray matter volume from magnetic resonance imaging, volumetric data, when we compared the group of normal, healthy persons with patients with Alzheimer's disease with dementia in gray, we could confirm the typical results of the literature showing a decrease of default mode network volume in patients with Alzheimer's disease and dementia. Then we compared the EEG source activity in the resting state as closed between Alzheimer's disease with dementia, circles, and normal elderly subjects, the triangles. And you see that we have a peak in the cortical source activity in the alpha frequency. In the triangles, the group of normal elderly subjects, as expected. We were able to localize these peaks of alpha source activity in the precuneus, in the inferior parietal cortex, and also some moderate values in posterior cingulate cortex, when compared to low activity in alpha source in medial prefrontal cortex and anterior cingulate cortex. In relation to triangles, normal subjects, the patients with Alzheimer's disease and dementia show a decline of alpha source activity in inferior parietal cortex, in precuneus, and in the posterior cingulate cortex. So this was a nice demonstration that Alzheimer's disease with dementia is characterized by changes of alpha rims in the nodes of default mode network, the posterior nodes of default mode networks. And another result was that the delta and theta source activity was greater in Alzheimer's disease patients with dementia than normal subjects in the inferior parietal cortex, precuneus, and medial parietal, medial prefrontal cortex, and anterior cingulate cortex. So the nodes of default mode network are deeply affected by brain atrophy and changes in alpha and delta rims, but only the alpha rims in the inferior parietal cortex was correlated with the neurodegeneration and atrophy in the default mode network. So this was another demonstration that in Alzheimer's disease with dementia, there is a deterioration in the default mode network and the mechanism of generation of alpha rims in a strict relation as underpinnings of the vigilance dysfunctions in these patients. Allora, potete accendere le vostre videocamere? Daniele, tu sei vivo? Dopo, ok, sei vivo. Allora, eh, eh, un'altra un'altra carrellata di risultati sperimentali sull'attività EEG registrata in condizioni di resting state eyes closed, quindi di vigilanza quieta, di rilassamento psicofisico, senza un'attività mentale focalizzata su degli obiettivi, su dei goal, per mettere in evidenza la nostra capacità di mantenere la vigilanza quieta e lo stato di rilassamento per i 5 minuti circa della registrazione. Cioè un test della capacità di mantenere stabile la vigilanza, che può sembrare una banalità dal punto di vista clinico, ma in realtà, come abbiamo visto, è utilissima per mettere in evidenza gli effetti di processi fisiopatologici del cervello. Abbiamo visto il caso delle lesioni sopratentoriali nei pazienti con stato vegetativo persistente che hanno un ritmo sonno-veglia conservato, ma guardano nell'aria e non rispondono alle voci dei familiari, dei parenti, dei amici, dello staff medico. Abbiamo visto delle altre alterazioni dell'attività elettroencefalografica nei pazienti con long COVID e brain fog, quindi quella sindrome che è caratterizzata dai difficoltà di concentrarsi, dalla difficoltà di memorizzare, da un senso di fatica, stanchezza mentale, che guardate bene, poi può non essere associato a un declino cognitivo misurato attraverso i test neuropsicologici. Quindi è soggettivo ed è collegato nella nostra interpretazione ai disturbi della vigilanza e dei sistemi che regolano la vigilanza quieta. Un altro caso che abbiamo considerato in diversi studi è quello della malattia neurodegenerativa progressiva della terza età, che è caratterizzata da un accumulo patologico di proteina a beta-amiloide 42 e di fosfotau. La proteina beta-amiloide 42 si accumula extracellularmente nel cervello a formare delle placche dure, caratterizzate da infiammazione, neuroinfiammazione. E abbiamo visto che in questi pazienti c'è un'alterazione dell'attività elettroencefalografica in condizione di resting state e di occhi chiusi, che è associata all'accumulo di neuropatologia del cervello misurata dal liquido cerebrospinale, è associata a una alterazione dei sistemi ascendenti cholinergici alla corteccia. Abbiamo visto il legame con il deterioramento di questi sistemi e poi anche con il deterioramento strutturale dei nodi del default mode network, un network corticale che è stato evidenziato dalla correlazione dell'attività BOLT in certi punti della corteccia cerebrale durante le registrazioni di resting state functional magnetic resonance imaging. cioè l'equivalente di resting state dalle immagini di risonanza magnetica. Ecco, questo è quello di cui abbiamo parlato oggi per, diciamo, formare, no, una base sulle rilevanza dei marcatori neurofisiologici elettroencefalografici per la parte che riguarda la perdita di funzione di vigilanza e in parte di funzioni cognitive nei pazienti con sofferenza cerebrale. Ecco, anche abbiamo visto l'attività epilettiforme nell'Alzheimer, che pure noi pensiamo sia associata a dei loro momenti di appunto vuoto mentale che concorrono ai loro deficit cognitivi. Ecco, questo è un po' quello di cui abbiamo parlato oggi, in preparazione poi appunto della parte che riguarderà gli atleti di elite. Allora, avete domande su quanto ho esposto?
No.
In realtà è
Ok.
chiaro. Vediamo un attimo poi gli atleti cosa ci...
Quindi abbiamo il polo delle anormalità, delle lesioni, delle disfunzioni, dei network che sono deteriorati e lì troveremo invece il polo opposto, no? La super efficienza neurale. Tutto attraverso questa tecnica centenaria, no? Ok? Allora, io devo darvi la notizia, che potrebbe anche essere una buona notizia, che a Luna c'è il consiglio di dipartimento di fisiologia e farmacologia, quindi devo assolutamente andare proprio fisicamente in persona nell'aula del consiglio di dipartimento. Quindi per oggi la lezione finisce qui e ci vediamo martedì prossimo.
Eh, non l'avevamo fissata alla fine, quella che dovevamo
Se volete
recuperare.
possiamo fissarla per martedì prossimo.
Io martedì avrei forse difficoltà. Ehm,
Allora, facciamo così, mettetevi d'accordo, io a quest'ora posso sempre, diciamo, quindi vedete un po' voi quando la
quali
potete
altre?
fare la settimana prossima.
Martedì per forza oppure...
No, appunto ti dico che parlate tra voi, se c'è un altro giorno che preferite, proponetemelo che probabilmente va bene perché diciamo adesso appunto ho solo lezione con voi.
Ok, perfetto. Noi più
Va
tardi
bene?
passiamo in istituto per una lezione con il professor Bernardi, eventualmente la possiamo disturbare un attimo.
Non ho capito.
Noi veniamo dopo in istituto che abbiamo una lezione con il professor Bernardi, eventualmente possiamo
Sì,
confrontarci.
venite pure, io tanto sono qui, a parte il consiglio di dipartimento a cui devo partecipare che è nel blocco di farmacologia, quindi
Ok,
il tempo di ritornare dopo il consiglio. Va
perfetto.
bene?
A più tardi allora.
A più
Arrivederci,
tardi.
arrivederci, buona giornata.
Arrivederci.